And we have been assured that the electricity bill has been paid. We are going to go ahead and call this meeting to order. Welcome to the second Health Services meeting. I almost forgot. It feels like we've been working in the interim for quite a while now. So this is our second meeting of the Interim Joint Committee on Health Services, and if everyone can please silence your cell phones, we will go ahead and have DJ please take the roll.
Senator Adams. Senator Berg.
Present.
Senator Carroll.
Here.
Senator Douglas.
Present.
Senator Herron. Here. Senator Mills. Senator Nemes.
Present.
Senator Rawlings. Senator Richardson. Senator Tishner. Representative Bratcher. Here. Representative Bray. Present. Representative Burke.
Here.
Representative Callaway.
Present.
Representative Camuel. Representative Dotson. Here. Representative Duval.
Here.
Representative Fleming. Representative Gordon. Representative Holloway.
Here.
Representative Marzian. Representative Neighbors.
Here.
Representative Proctor. Representative Rayburn. Representative Raymer.
Here.
Representative Riley. Representative Sharp.
Present.
Representative Wilner.
Here.
Co-Chair Meredith. Co-Chair Mosier.
I am here.
Good.
Okay, we have a quorum established to do business, and I'd again like to welcome everyone. I would like to just let everyone know that Senator Meredith is very busy supporting his son, Chad Meredith, in D.C. right now. This morning is his confirmation hearing for U.S. District Court Judge, so we wish him well. And do we have anyone who would like to make introductions? Welcome anyone? Okay. We would first need to approve the minutes from our June 18th meeting. Do I have a motion to?
Motion.
Okay, second. All in favor, please say aye.
Aye.
Any opposed? Okay, thank you. Okay, we will go ahead with our agenda, and I would like to welcome our new Cabinet Secretary, Cabinet for Health and Family Services Secretary, Dr. Stephen Stack, and Dr. John Langfeld, the Commissioner for the Department of Public Health, to come on up and introduce yourselves to us in your new roles and tell us about your priorities. Just introduce yourself for the record. You know the drill. And go ahead and proceed. Welcome.
Good morning, Chair Mosier. It's nice to be here. So, as I think you know, I'm Stephen Stack. By way of introduction, although many of you know me, there's been turnover over the last 5+ years. So I'm an ER doc by background. I live in Lexington. I practiced emergency medicine in Lexington right up until just before I took this role. I had intended to continue practicing medicine and had arranged to do a little bit of that, and then COVID changed our world, and that sort of adjusted my plans going forward. I don't know how long I intended to be in government, but I would describe myself as one of those people from the private sector who was curious what it would be like to be in government. The fact that I'm here as long as I have been and will now continue to serve in the administration in a new role is both a privilege and unexpected. It's not what I thought I was going to do when I started out, but here we are. And when I was the Commissioner for Public Health, it was very, very important to me that the Department for Public Health was a resource to everyone we served, all the Kentuckians, of course, the executive branch, but the legislature as well. And now that I'm Secretary, that same approach applies to the Cabinet overall. I'm very grateful for Secretary Friedlander and his leadership. I think you all know he had a very distinguished 40-year career in civil service, and his knowledge and familiarity with these programs and the work it does was really, really impressive. His passion and commitment to serving Kentuckians was unrelenting all the way through to his final retirement day, which is actually officially tomorrow. So if you see him, please congratulate him and wish him well. And I look forward to working with you in this new role and hopefully doing good things for the people of Kentucky.
Well, good morning, Madam Chairperson and distinguished members of the committee. It's a pleasure to be with you today. Thank you for the opportunity to be here. A little bit of my personal background, I'm a native Kentuckian, and have spent most of my life and career in Kentucky, and had the privilege of seeing many different communities around the state. I was born down the road in Harrison County, Cynthiana, and graduated high school in eastern Kentucky, Lawrence County. Attended Berea College, and went to medical school in Louisville, and then moved to do my residency in northern Kentucky at St. Elizabeth. And so saw a lot of the state, through a lot of different lenses. I had the opportunity, I spent over 3 decades in clinical care, serving citizens in our state, and had the first opportunity to join the cabinet a little over a decade ago in the Department of Medicaid Services as the chief medical officer. And a wonderful experience at the time. When I left there, I spent some time working with several hundred hospitals across 5 southern states in their quality and safety initiatives. And then about 3 years ago, had an opportunity to start working again with organizations in Kentucky with the Kentucky Primary Care Association, and some work focused on KHIE at that time. And about 2 years ago, had a conversation I began with then Secretary Friedlander, and who wanted to initiate a movement to really say, how do we focus on quality in our state? And so last year joined the cabinet again full-time to continue that pursuit with the cabinet. And recently, as Dr. Stack has now moved into the secretary's position, have had the privilege and honor to become the commissioner for the Department for Public Health. So again, I'm very privileged and honored to be with all of you today, and look forward to our time.
Well, wonderful. Welcome back to state government. I guess you haven't left for a little bit, but it's good to see you again, and we welcome you. Thank you for your service to both of you. And I'm very interested, and I guess while you're still at the table, we'll just keep you there and have you talk a little bit about KHIE. You mentioned KHIE, and we want to talk about data collection today. Where does health data collection or health data come from? How do we collect it? How is it linked? How do we use it to really inform our policy decisions and those quality metrics that you mentioned? So I think I'll just let you go ahead with your testimony, and we can ask questions. We've got some other folks who are also experts in this area who are going to help with the discussion. So I hope it's an informative just discussion this morning, and we can really talk about how we best collect health data and use it for quality metrics and improving healthcare quality in Kentucky. So
we were going to tag team this. I was going to give a broad overview, and then John was going to go a little bit more deeper. So,
okay.
So KHIE is the State Designated Health Information Exchange. KHIE, some of the stats about this I think are really impressive. We have over 18,124 interfaces that connect to 720 organizations across more than 6,000 individual points of care across Kentucky. Every acute care hospital in the state is connected. All the laboratories are connected. Quite a few of the office-based practices and smaller clinics are connected. And of course, there's interfaces with federal data systems, with a variety of state data systems. Think about Casper for reporting prescriptions for controlled substances. There's other data systems that you've heard about over the years, like Twist for the case management for the social workers. We also have relationships with University of Kentucky through the Kentucky Injury Prevention Research Center, so KIPRIC, and they do a lot of injury research. The system connects electronic health records to the state through KHIE, and so we're able to get notifications about admissions and hospitalizations and discharges and transfers. That information helps support the clinical care team, because through KHIE, different hospitals not on the same IT platform can share clinical information protected by HIPAA and with all the appropriate safeguards, but they can share clinical information. There's radiology information, so MRIs, CT scans, plain film x-rays, data that's shared through KHIE between different hospitals and other healthcare providers. There's also, if you're a primary care physician, you can get discharge notifications if your patient was admitted to the hospital and get notified that your patient was discharged, so you can hopefully reach out and engage in follow-up to reduce the risk of them ending up back in the hospital and ensure they get the follow-up care they need. These data systems also made it possible for us to run the immunization registry, where people can report data to us through the immunization registry, but then we can report as required up to federal data systems as necessary, and support a platform where patients or citizens can go online and request an immunization record of their own that is produced at home. I've done that for my own family, where you can pull down what's in the system and see. And so that's all on our website for how to do that. It supports Medicaid providers, Medicaid MCOs, information shares for claims and processing through there. I said the DCBS caseworkers, reporting to registries for laboratory data. We have reportable diseases in Kentucky, things that are particularly contagious. So like if a case of smallpox ever were to emerge, that's a reportable disease. That would be like warning, the most alarming thing we could see happen. Well, if someone got a positive smallpox test, they'd have to send it through that, report it to the state, and KHIE would help make that possible. For things like influenza and RSV surveillance, so we can predict, does it look like the hospitals are going to have more patients? The labs at the hospitals report electronically, so it's all automated, into a data system, and then we can produce dashboards. And so those kinds of data are on our website at coveryourcough.ky.gov, where we show in the fall and the winter season data related to influenza, RSV, and COVID for whether the cases are going up or not based on that laboratory data. And then it supports aspects of Connect Resources, and we are also working with the Department of Corrections, and KHIE will work with that for our reentry programs to try to help make sure that inmates upon release to society have the supports they need to be successful and to reduce recidivism, and to ensure that they have an opportunity to rejoin society in a productive manner with the supports they need to make that transition smoothly. So that's sort of an overview of KHIE. When we first started it, it really was a leader. It was an industry leader. We were and are one of the few states that operates our own health information exchange. And we're on a modernization and transition plan now to further enhance that in partnership with other states. And so I'm excited about this. It's clearly something that we need, and it's something that the state and the people in Kentucky benefit from substantially. And so John's going to pick up from there.
Yeah. Thank you, Dr. Stack. I've spent a lot of time in my journey around this concept and how we think about data, how we use it effectively. So we could have a very long conversation. I know our time's limited today, but I just want to make a couple of comments and overarching thoughts about data itself, why it matters. In our work in the cabinet, in public health, and I think collectively with all of you, data is one of our most powerful tools. And I'd like to start with just a simple description. Data helps us listen, and then, as importantly, act. It helps us to detect patterns we can't see in individual stories. I think of it as a clear signal through all the noise that helps us move from anecdotal assumptions and anecdotal stories to get to evidence, and then we can move from evidence-supported information to action. And so one of the things that the signal can do is it can help us respond faster, it can help us target interventions, it can help us target resources and make a bigger impact. And so, I saw this morning, as probably all of you did, we had a earthquake and a tsunami, and I often use that example when I talk about data. In 1950, data was estimated to double every 7 years. Today, it's estimated that it will double every 73 days. And one estimate put that healthcare data, if we look back at the history of healthcare data, that all of the history that has ever been generated, 90% of it's been generated in the last 2 years. And so we literally are living at a time where it's unprecedented as far as the amount of data we're trying to digest and then figure out how to use most effectively. And so as in our work, then I think we have to think about how we identify the data sets, how we access them, and then more importantly, how we begin to pull them together and integrate. We've done an analysis, I think Dr. Stack mentioned it, in the cabinet, and we have over 200 data systems just within the Cabinet for Health and Family Services alone. And so our work is really to think about how we look at public health and Medicaid and behavioral health and clinical data and social and economic data, and how we begin to pull that together, because our goal is to create the most holistic and complete view of the needs in our communities so that we can respond to them as effectively as possible. And I think our data is not just about charts and graphs and metrics and reporting the past. It's really about real people with real problems, with real decisions to make. And our response using data needs to be as real time as possible as we move forward. I think if we use data effectively and keep it connected, understand how to use it, and how to move upstream with it, it can be proactive, and we can move with purpose in really supporting and leading our communities. And Kentucky can be the lead in building a healthier future for us all. I'll just make a quick comment about KHIE. Dr. Stack covered all the details pretty effectively, but KHIE is one of our most important tools. And as he mentioned, it really connects the touch points in our communities, our hospitals and providers and labs and pharmacies and public health systems into a secure network. And without that, we can move away from functioning in the silos that we historically, I think, naturally fall into, and figure out how we can be more coordinated and harmonized. Now, to do this work and to continue to advance this work, I think there are some real needs, and I'd like to provide 4 things for your consideration. One is we need to continue our investment in KHIE and also in our state infrastructure development. Number 2, we need to truly support interoperability between systems, because only with that can we get flow of data and create that information that we need in real time and create the transparency that everybody talks about, wants, and needs. Number 3, I think we need to promote frameworks that enable data while still ensuring our privacy and our citizens' privacy. And then 4th and lastly, in this tsunami of data, we have to grow our analytic capacity, capability to turn data into true action. So with that, I'll pause. I know that, again, we could talk about it for a long time to entertain any questions you might have.
Okay. Do we have any questions from the committee? No, I don't see any. Oh. Senator Tishner.
Thank you, guys. Thank you both for being here, and congratulations on your new roles to serve Kentucky citizens. You mentioned the data and the evidence and how powerful that can be to help inform public health. So we've recently gone through this COVID phase, and we're seeing the COVID vaccine now no longer recommended to pregnant women or children. And I want to know what you're doing to recommend for our public health departments to make sure people coming in who are vaccine are fully informed of the potential risks now that are now known.
Go ahead.
So in all of this, informed consent and education of a patient has been part of this process all along. So every time a patient goes to seek medical care, they engage with a clinician. They should be engaging with a licensed healthcare provider who's licensed and overseen by boards of licensure in the state. And they should discuss their specific circumstances, have their questions answered, and then make an informed decision about what they would prefer to do. So I think that process has been in place and continues to be in place. And so the vaccines are still FDA approved. The evidence is very compelling that they reduce danger and risk. Pregnant women are immunocompromised, are considered immunocompromised by the very virtue of obstetricians just describe them and define them as immunocompromised as a result of the extra strain on their body for bearing the unborn child. And so the American College of Obstetrician and Gynecologists still recommends that pregnant women be vaccinated for COVID. So, but that is a decision that would be made between the patient and their licensed healthcare provider. In Kentucky, we never mandated or required the COVID vaccine for anybody, the state of Kentucky, not the executive branch or the legislative branch. But we do encourage it and still recommend it for those high-risk populations, which medical professionals define to include pregnant women.
Do you mind if I have a follow-up?
Yeah, sure.
Okay, you said several things that were quite shocking to me, but people lost their jobs over that because of the forceful recommendations coming down from our state government. And the damage that was done is just atrocious, and we've really not ever recovered from that. But back to my original question, there is information that's exchanged between a doctor and their patient, which is obviously so important. But how are you recommending the patient has full informed consent on the dangers of that vaccine, especially from our public health departments and people who come in to ask about that? Because I don't know if you know, but the ingredient list was blank. It was a blank sheet of paper. No one knew what was in that vaccine. Now we know, and now we know the dangers. How are people getting that informed consent?
By engaging with their licensed healthcare provider, like I said. And as far as for us, I think the evidence is overwhelming that the benefit is overwhelmingly positive. And there are others who, there's different perspectives people can take, but the scientific evidence is that we've given those vaccines to billions of humans and saved millions of lives, and that the disease triggers an immune response, which has been shown to be very dangerous to people. In the beginning part of the COVID pandemic, people were losing their lives in large numbers. And then as the pandemic evolved, as we got exposed to it over an extended period of time, and as people were immunized, that also bolstered their immune system. Thank goodness that disease has become a less severe disease, but we still have lots of people reporting extended brain fog and fatigue and respiratory difficulties and extended things. And one of the things that's captured attention is cardiomyopathy, but when you get the COVID disease, the cardiomyopathy that young people have is more severe and causes more harm than the small number of people who get any kind of cardiomyopathy related to immunization. So the overall evidence is still that these vaccines are highly safe, highly effective, and reduce disease and morbidity over time related to them. So I do appreciate that there are other perspectives. But I would ultimately say what I did during COVID, which was I have consistently, I think, encouraged people to seek professional medical advice from a licensed healthcare provider and consider their medical choices in that context. Now, at scale for population health, we have recommended and continue to recommend immunizations, the routine immunization schedule, including that for COVID, for people who are defined to be at high risk. And so we'll continue to support what we believe science sustains and recommend that to folks. But as recently as my transition here into this new role as secretary and my media interviews when this has come up, I have consistently encouraged people to consult their licensed healthcare provider for personalized, high-quality information so they can make their best informed decision. I'll end by saying, in our routine lives, it has always been important, and it's a hallmark of medical practice, that patients be given the opportunity to be fully informed and make an informed choice about their health care. And that is the way healthcare overall should be done in a routine manner. COVID was not routine. It was a global pandemic that disrupted all of humanity. But in a routine world, we always support patient primacy and autonomy in being able to make an informed choice.
Thank you. I would appreciate maybe a conversation in a different format further. Thanks
Sure.
so
Thank
much.
you, Senator.
Thank you. Okay, we're going to finish the conversation on vaccines and move back to data. But I do really appreciate the conversation and the fact that we have this information through data. So next we have Senator Heron.
Thank you.
Sorry.
Thank you. And congratulations to both of you on your new role, and I'm excited to see what you are able to do to help continue to move our Commonwealth forward. John, there was two things that you said toward the end of your remarks. You talked about promoting a framework, and then you talked about turning data into true action. And you all mentioned KHIE. And so my question is that how can we utilize KHIE and the work that they're doing around firearm injuries? I know that they released a report in 2024. How can we use that department to help inform us better around what we can be doing to prohibit firearm injuries, whether they're accidental or non-accidental, fatal or non-fatal?
Yeah, thank you for your question. I'll just comment again back to the comments that I made about, number one, how do we identify the sources of data that exist today? How do we begin to access and extract that data so we can connect it? KHIE is a wonderful, it's been a long time resource, and it really does help us inform ourselves in many ways. I think the opportunity there is how, just like any of the databases that we can access today, is how to make them, instead of being sort of places we look retrospectively a year or two behind, that we begin to think about how do we move the data more real time so that it can be usable as we work and respond to needs every day. And I think you were going to talk about the firearm piece.
Touch on that. And just to add what Dr. Langfeld said with KHIE, and I think Dean Bush is probably behind me here somewhere, that has been a multi-decade relationship, and we do a lot of wonderful work with KHIE, and we're very grateful for that partnership. So we'll continue to support that. When I was president of the American Medical Association, one of the last public statements that I made before I handed over to my successor was declaring gun violence a public health emergency on behalf of the American Medical Association. I continue to believe that. That being said, we live in a society that has very divided opinions about firearms and their role and their place and how they should or shouldn't be overseen. So what we're committed to in public health, again, is trying to inform people, but also not get ahead of in certain areas where our people and our society are. And so for right now, the data is available. It's in the system. Authorized entities can use data like that to do research, but beyond making data available under appropriate conditions for people to do research, I'm not sure that there's a other specific role envisioned at the moment for the Department for Public Health or the Cabinet specifically. But again, recognizing that for some that will be good news and for others that will be a shortfall, I just acknowledge that this is a topic that's been very difficult for society, and I acknowledge that openly. I still believe that we need to find a way to make firearms available in society, consistent with the Constitution, in a way that people can use them appropriately while still mitigating the harms of gun violence when we continue to see mass shootings as recently as this past week, which are tragic. And I think we're all committed to avoiding those tragedies. The challenge is there a way for folks of differing worldviews to reach commonality on things we can do to try to reduce those risks? Because no one, not gun owners and not those who oppose gun ownership, no one wants those tragedies to occur. We just have very different views sometimes about how we might get to that place. And we're committed to trying to support, in a complicated world with information, people making reasonable, informed decisions.
Thank you. And that's kind of the beauty of data. It's just numbers. It's just the facts. So that's what we want to get to. Senator Byrd.
Thank you, both of you, for being here and for your service to the Commonwealth. It is extremely important. I have actually, if it's okay, Madam Chairwoman, two questions. One would be a follow-up to Senator Herron. With the data that we have, the two registries that I used my entire life were the Cancer Registry and the Trauma Registry. Those were the two registries that impacted the work I did and the research that I did. Do we have a way, with the data that we have currently, simply to use it to estimate for the state the cost to the state of gun violence, so that we can understand realistically that what we are spending, what public money is being utilized to mitigate the damages caused by gun violence in this state. I think if people understood the millions to billions, they may be a little more appreciative of some sort of tamping down of the extent of that. Is that possible from the data you have?
Let me respond to that in a couple of ways. When we talk about cost relative to any disease or activity, it's many times not as straightforward as saying A is connected to B. And then that's frankly one of our challenges, because sometimes we get information early on and we make what we call observational correlations, assumptions about that. And then, but ultimately, there's a difference between correlation and causation of true cause and effect, and making that linkage. And so, when we're talking about something as complicated as that, we really have to begin to think about the layering of the data, where are the gaps that exist, can we obtain that? It includes social and economic data. It includes, a lot of data from different sources outside of health, what we would traditionally call health data. And so when we have important questions, particularly as it may relate to policy decisions, for example, I think we need to approach that in a very pragmatic way to make sure that the assumptions are validated, and that if we're going to make decisions that we do it on good evidence rather than on assumptions that we double down on sometimes.
Follow up on that. I understand exactly what you're saying, but I've worked in an emergency room for 40 plus years, and I can tell you the cost of gun violence in this state is rising, because the incidence is rising, and the majority of people who at least show up in the University of Louisville are not privately insured. We are covering the costs of this. My second question.
Quickly, please. We've got a lot of people to testify.
Thank you. This will be very quick. It's a yes or no. Do we currently maintain statewide cancer and trauma registries?
Yes. The cancer registry, the Kentucky Cancer Registry, is a separate entity entirely. And that's in statute. And there's a separate entity, and it operates that. And we work with them, but that's not under the oversight or authority of DPH. That's a separate entity. As far as the trauma registry, there is a trauma registry. The thing that I don't want to overstate is I'm not familiar with the data elements that they collect in there. So that's a defined trauma registry for a specific purpose, and there's a Kentucky Trauma Advisory Committee that's in statute, and those individuals help oversee the execution or implementation of the trauma system and also that registry. And that's something that we work with the Kentucky Hospital Association, and I think U of L has a prominent role. UK and U of L both, because they're the two level 1 trauma centers, but I think U of L is engaged in the oversight of that trauma registry. And so that, again, we rely on partners to do some of that work.
Okay, we have a couple more questions, 3 more questions, but I'm going to ask you all to hang on to those for just a few minutes, because I'd like to bring up our public health data folks, and maybe some of your questions will be answered. If not, stay nearby if you don't mind. Thank you. All right, next we're going to hear from Dr. Heather Bush, the Dean of the UK College of Public Health, and Dr. Eric Durbin, who is an associate professor in the Division of Biomedical Informatics at the UK College of Medicine. Welcome. And and you are also the Director of Cancer Research Informatics. So we're going to go ahead and let you introduce yourselves for the record, and you see the direction of the conversation. And so go ahead and proceed. Thank you for being here.
Good morning. Thank you so much for having us. Thank you, Chair Moser and committee for allowing us to speak today. My name is Heather Bush. I am the Dean of the College of Public Health. I am a proud University of Kentucky alumni, and I will be starting my 19th semester this fall at the University of Kentucky. I'm a professor of biostatistics and most recently have the privilege of serving as the Dean of the College of Public Health.
Good morning. Thank you, Chair Moser and the committee. I appreciate the opportunity to speak to you today. My name is Eric Durbin, and you've noted some of my roles. The other role is I'm director of the state's Kentucky Cancer Registry, so I really appreciate the questions, interesting questions about the Cancer Registry, which is exactly what I'm going to speak to this morning. My background, I'm a native Kentuckian. I've been involved with the Cancer Registry going on 35 years now.
You can go ahead. Thank you.
So we have a brief presentation for you here, just to kind of get things started. KHIE has already been mentioned a few times, so that's a nice segue for me. One of the things that I will mention is that really being able to work with data to help people is the strategy. And in the academic side of public health, our goal is really to innovate in ways to try to share data out for that decision-making piece. And so KHIE is one of our long-standing examples of how we do that work. They provide data and oversight and surveillance and provide briefings to lots of different agencies and for personnel decisions, resource allocation, and legislative action. Just this month, we're in the process of moving some contracts from Medicaid and DBHDID into the College of Public Health so we can better support those initiatives as well. But what I really want to talk to you a little bit today about is RADOR, which is our new strategy for modernizing how we share data out. And I'm not really talking about a data warehouse here. I'm talking about an analytic engine on how we can look and view data. And so RADOR is funded by the National Institutes of Health. It was funded for the development of RADOR. It was originally set up to look at the opioid epidemic, but because it was federally funded, there is no licensing fee. It's open source. And as they developed it, they really worked to make it agnostic to any data type. So although it's focused right now on opioid overdose prevention, it really could use any type of data. One of the key features is it is designed to be centralized and pull lots of different sources of data together. There's there's over 50 different data usage agreements that we currently are working with in the college and really trying to pull those data pieces together. You can see from the slide here that it was developed in collaboration with our research centers and also with the cabinet and different local and state partners. One of the key features of RADOR is that it was focused on the end user. So how are people going to use data? What are they missing? And how do we put priorities into the hands of local leaders who are making decisions every day? And so one of the things that we can do with visualizing data with this RADOR system is that we have some unique geographic groups in Kentucky, whether it be our 120 counties, our local health department districts, or our area development districts. We are looking at data in different formats, in different views, at different local levels. Another characteristic of Kentucky data that we have is that some of our communities have small population sizes. And so sometimes when we get a report out from one of our aggregate data sites, that particular community has just a blank sheet. Everything's suppressed because there's too few counts and you don't want to make the data identifiable. Here we have some analytic strategies to provide ranges so that those small cell counts don't result in blanks, but actually still provide an opportunity to look at those trends. One of the really exciting things about this new system is the request that we had from our end users that they didn't want to just know about past data, but how do we make decisions going further? And so in some of our areas in Kentucky, in the opioid overdose, we don't necessarily have the same needs as others. And so being able to identify hotspots, what are new hotspots, what are emerging hotspots, where does resource allocations need to live so that we can proactively try to meet the needs of those communities. So being able to use spatial analysis to identify those hotspots. And then again, another request that we had from our end users was, okay, it's great that we have the trend analysis, but could we look into the future? So using artificial intelligence and machine learning, we have the opportunity to look a few months right now. Maybe later we'll be able to go further, but to look a few months ahead and try to predict where there might be needs, how can we better prepare and respond to potential health issues. And so really in this system, we're really just always looking for ways to prepare. We're currently working on custom dashboards. One of the asks that we often get is, how do I look at my data? People are putting data in, but they don't necessarily get to see their data. So being able to have a login of access so that people who are restricted users can look into more detailed views versus a public view where everybody can have access to that data. We are keeping up with technology and innovation and trying to make the experience better using AI. And there's partners in the audience right now of how we can work and share these tools to expand it to other data elements, working with Kentucky Health Directors Associations and other groups on how we can make those local partners have data available to them. And so those are just a few of the ways in which we are taking all of our different data sources. This is our contribution to making Kentucky healthier. Thank you.
Questions now, or do we want to wait and I'll
If you
present
want to
them
go
then.
ahead and present your information, we can hold questions for a minute.
Absolutely. First, I should point out that Dr. Bush was my professor of biostatistics many years ago, and so everything I learned about biostatistics, I learned from Dr. Bush. And let me tell you, she was a fantastic instructor. Next slide, please. So I'm here today to talk about the Kentucky Cancer Registry and the data that we collect and how we make those data available for policymakers and the public. And I usually start my presentations about the registry with a map such as this one. This is showing cancer incidence rates in the United States between 2017 and 2021. And every time I've seen this map throughout my career, maps like this, and my heart sinks every time I see it, because you see in the center there, click please, Kentucky just stands out. So Kentucky has more counties with higher incidence rates than any other place in the nation. So the burden of cancer in Kentucky is truly breathtaking, and particularly in our eastern Appalachian region of the state. Next slide, please. And so how do we know that? So the only way that we know the burden of cancer in Kentucky is through our population-based cancer surveillance programs. And of course, it exists in Kentucky and in most U.S. states, all U.S. states and most territories. Cancer is a reportable disease mandated by state laws. There's no federal mandate for the reporting of cancer. Kentucky's law has served, I think, the Commonwealth quite well. KRS 214.556. It established the Kentucky Cancer Registry at the Markey Cancer Center in 1990. And it specifies that all facilities that diagnose or treat cancer patients shall report that information to the Kentucky Cancer Registry in a format prescribed by KCR using the Cancer Patient Data Management System. And that's a software application that we developed and have maintained for over 30 years now. How is the registry funded? 22% of our funding comes from the Commonwealth of Kentucky through the state legislature. 16% of our funding is through CDC with the National Program of Cancer Registries. And almost 62% of our funding comes through the NCI Surveillance Epidemiology and End Results Program, or the SEER program. And SEER is considered some of the very best cancer registries in the United States and perhaps worldwide. As a result of the recent federal funding cuts, we received a 17% cut in our SEER budget, unfortunately. But data sharing for evidence-based decision-making and research is a fundamental component of KCR's mission. Next slide, please. So I'm going to describe for you now. It's like, how do we make this incredible data that we collect readily available? Well, there are a number of keys, in my opinion, for effective health data sharing. Standardized data collection, following a standardized way of collecting data is incredibly important. In cancer registries, we follow the standards promulgated by the North American Association of Central Cancer Registries, or NACER. And I just happen to be now the elected president of NACER starting this year for a period of 2 years. Ensuring high-quality data in terms of accuracy, completeness, and timeliness is essential. Our registry has a lot of procedures and methods for accomplishing this. Of course, it's patient data, and so protecting patient confidentiality is essential, and then providing multiple avenues for relatively painless and widespread access to data, and we do that in a number of ways through KCR. First and foremost, the hospitals that collect and report data to the registry, from our perspective, they own their own data and they have complete and total access to that. It's maintained in our CPDMS system and they have full access to that to do with that data whatever they wish, so for their own cancer commissions or whatever purposes. We place the state's registry data on a public website at KCR. We generate maps that make it very easy to look at any type of cancer, any number of years that we've collected data by sex and race and a variety of geographies, so county or Appalachia, which is incredibly important, area development districts and so forth and so on. If you haven't been there, please go to our website and check it out. Because we're part of the SEER program, which is the NCI SEER program, our data is incorporated into an application called SEERstat, and this is an analytic biostatistics analytic platform that's freely available, and as long as an individual has appropriate credentials and promises not to abuse or misuse those data, they can download that. And all Kentucky incidence data are available through SEERstat. We also enjoy taking our data and information on the road, so we've a number of prepared presentations I've presented to this committee before. We speak to our area development districts, to the cancer councils there, the screening programs, Senator Douglas and Representative Neighbors and Chair Moser. I think you guys have been privy to some of those presentations, which have been very impactful. By presenting and using the registry data, we see where the burden is, we plan interventions, and then if those interventions are successful, then we will see a change. And particularly in lung cancer, we've seen a dramatic shift as a result of emphasizing in a statewide lung cancer screening program. We've seen a dramatic shift towards earlier stage of diagnosis for lung cancer. And stage matters. If a patient is diagnosed early with lung cancer, they're more likely to survive, and you can imagine the healthcare costs are going to be reduced as a result of that. So that is one of our great success stories. In a variety of other areas, we also present these data. Our data are readily available for research, and we have a formal application and review process. We've defined several levels of data, aggregate data. If our website doesn't answer the question, we'll be happy to aggregate data in a special way for folks. De-identified records are available. Sometimes people have other data sets that relate to cancer patients, and they want those linked to the registry to maybe identify a specific diagnosis in their database. We also provide geolocation data, and then we also support patient contact studies. So an investigator can come to the registry, and we will facilitate contacting patients throughout the state to give them an opportunity, if they so choose, to enroll in a research study. And of course, IRB approval may be required depending on the level of confidentiality of the data involved. Next slide, please. So we are actively involved in creating and working towards a future vision for broader cancer data sharing and use. We're involved in several national initiatives, and most of these initiatives I'm citing here are related to either collecting data more efficiently or making data more powerful through integration with other data sources, broader access to data for more patients, even outside of Kentucky. We are participants in the National Childhood Cancer Registry. I think a number of you have met me to speak about the high cancer burden we have amongst our children, brain tumors in particular, and a number of other cancers. We publish an annual report of that. If you haven't seen this, if we've done our job properly, hopefully you already have, but if not, I'd be happy, and this is on our website too, be happy to discuss this with you or share a copy of the printed report. NIH reached out to us recently to participate at UK to participate in the data counts, which stands for collect once and use numerous times. I think NIH realized that they may be paying for data for one group and then paying for the same data for another group. And so the idea is you collect data one time, and then NIH, for a variety of projects, a variety of disease groups, can utilize those data. We've also been approached to participate in the National Clinical Cohort Collaborative, or N3C. It actually began as a COVID data collection system. I believe they collected the largest repository of patient COVID data in the United States. And now they're moving on, using some methods and using the things that they learned through that project. They're now looking into cancer and nephrology as use cases using those same methods. We're leading some regional and local data sharing initiatives. You may have heard of Accelerate, the Appalachian Intercity Pediatric, Adolescent, and Young Adult Cancer Data Ecosystem. I came up with that acronym. I apologize, but it does spell Accelerate at the end of the day. But in this application, childhood cancers are rare, and molecular subtypes of childhood cancer are even rare. So it makes it really challenging to look for trends or to look for biomarkers and correlations with outcomes and successive treatment with small numbers. And so the idea was to create a larger cohort of patients, including patients in Kentucky, West Virginia, and Pennsylvania, all Appalachian states where we've identified particularly high rates of childhood cancers. At the Markey Cancer Center, the Kentucky Cancer Registry has created the Cancer Research Data Commons with the assistance of Markey. We use an application called CBioPortal where we're integrating molecular data, and this is looking at the tumor molecular makeup, linking that and integrating that with clinical treatment and outcome data from the registry, and making that easy for investigators to identify a cohort of patients and then take a deeper look at the molecular data if they so choose. We're also talking about expanding the use of KHIE. KHIE could probably provide maybe some easier access to data for the registry. And I think it would be important to put the registry data and make that available through KHIE. So a clinician treating a cancer patient, if they could ask KHIE for information about that patient's history and prior cancer that they may not be able to get directly from the patient, I think that would be an advantage for clinicians treating cancer patients. And then maybe I won't go through all the details. I know we're limited on time, but there are other national data standards initiatives in which we're involved as well. So I think that's it. Thank you.
Okay. Ooh, I think we asked the right people to come and talk about this. I'm very excited to hear about all of the work that you're doing, and especially on the cancer research. I passed the lung cancer screening bill to initiate that advisory council, and I'm so excited about the work that's being done and the fact that we are catching and detecting cancers earlier and treating earlier, and that's really that's the name of the game, right? So I am glad that everyone has been here today, and we still have some other folks who are going to talk about maybe what we need to do moving forward to help link and help with linkage to all of the cabinet, to legislators making recommendations to us in terms of how we can help others really access needed data. I am very excited about the role that some of the AI and predictive analytics can play and the potential for prevention, and that we talk about this a lot. And I really think that having the data available is what will inform some of those policy decisions. So I could go on and on. I'm just very excited about some of the programs that you've referenced, SEER, STAT, and the RADAR programs. And how do we, I guess one question that I would have is how do we, and I guess, through data collection, we can identify duplication of data collection, and how do we centralize all of the data and really make sure that it's linked to the appropriate agencies and people?
I'll take a quick start at that and say that I think one of the challenges we face is the data usage agreement component. As you mentioned, these data often live in these different silos. And so, it probably would take us about 6 months to get a new data instance of Radar, for example, for maternal and child health, or to expand KHIE and move KHIE onto Radar with some of their injury prevention data. But the challenge is making sure those data usage agreements are in place and they're used for the right things. And so I think that's one of the barriers that we see in the delay of getting data out is making sure those data usage agreements go smoothly. The opportunity to pull it all together is really what makes these systems work. And so I agree with you. I think one of the challenges we face is that the siloed nature of the data really prevents that integrative, comprehensive strategy for looking at it. So I guess my response to your question would be ways in which we can work together across different agencies and pull that into a centralized source would make our jobs much easier.
Yeah, I think I would concur with that. I think you have to think carefully about how you intend the data to be used. I can assure you there's a lot of nuance in the registry data. Our data standards evolve over time, and it could be misleading if you didn't understand that the definition of a variable had changed in a certain year. You can misinterpret that. But that being said, I think it's through a collaboration. If we think carefully and thoughtfully about how we intend to use data, then I believe that we can work together to develop mechanisms to do that. Another area of interest that I have, and it's not just me, it's the cancer surveillance community, is more real-time data. It takes a while. It takes about 2 years before we have complete population-based data for the state of Kentucky, and this is the way it works across the nation. One of the challenges we have is a number of cancer patients are seen in other states, and so those data in particular tend to take longer to make their way to our registry to be integrated. But we're looking at maybe using pathology reporting, and maybe if it were easier to access molecular data. Some of the companies that perform molecular testing are reluctant to share those data with us, and it makes it challenging. And so I spend a lot of time with attorneys working on data sharing agreements so that we can get access to those data. So maybe making that infrastructure easier to build, getting earlier access to data could be important so that we can make better decision making in a more timely fashion.
Right. Yeah, exactly that. And, we're just looking for ways to improve data collection, better recommendations, earlier preventative models, and how to appropriate resources to all of that. So I'm excited about the future and the work that you're doing. I think that we are really in an interesting and an exciting time to really look at what we really need to focus on. And that being said, we have our new Medicaid Oversight and Advisory Board, another area that we are looking closely at, and just having the ability to really audit those systems and look at high value care, low value care. What are we really paying for? And so it's all of it is a concern, and we need to look at not only health outcomes, but our resources, our limited resources. So thank you very much for your part in all of this and your important work. And I know that we had some questions earlier. I don't know if your question is still relevant. Representative Fleming, where are you?
Thank you, Madam Chair. My question is really for the Secretary and the Commissioner.
Okay.
And I'll follow up with the Dean Bush on some some questions I have about what y'all do. So.
Okay, so I guess I should just ask, does anyone have a question for Dr. Bush or Dr. Durbin? Senator Mills?
Yes, thank you, Madam Chairman. Just one thing, you mentioned your Sears funding was, the federal funding was cut by 17%. Is that an immediate funding cut, or is that phased in over 3 years?
No, unfortunately it was immediate. So we learned about that budget cut just a few days before our contract was renewed for that period. So it was immediate, yes.
Senator Byrd?
Thank you. Are we confident that our incident rate is really higher, or are we doing a better job than other states reporting?
Yeah, that is an outstanding and insightful question. I believe it is, and it's not just my belief. We have evidence of that. So the registry captures incidence data, as you're clearly well aware. So one way we can verify the incidence data is looking at mortality. So how many people are dying from cancer. And when we look at mortality rates in cancer, we see the mortality rates are very high in Kentucky, the highest in lung cancer. Like for example, we're not the highest in breast cancer incidence. We're actually about middle amongst the middle of central states. But if you look at mortality from breast cancer, we're relatively high, and that's probably because we're not actually identifying enough breast cancers early enough so that those patients can survive. But mortality backs up the information that we have in incidence. But to your point, I think we have an outstanding cancer registry in Kentucky, but we're part of the SEER, and all the SEER registries are outstanding. And so I believe our rates are factual and real.
Okay, thank you. Seeing no further questions for these presenters, I just want to thank you again for being here. And then does anyone have burning questions for Secretary Stack or Commissioner Langfeld? Okay, we do have a few more questions, so my apologies. If you could just jump back up to the table, we'll take care of these questions and then move on to our next guest. Thank you so much. Representative Fleming.
Thank you, Madam Chair. Secretary Stack and Commissioner, thank you all very much for being here. I wanted to ask you sort of a two-part question. First of all, how are you using the data to address the behavior of people to strive to have more healthier lifestyles? And if you can, give me some examples of those. In addition to that, we got around $22 billion that we handle in Medicaid, around nearly $3 billion when it comes to SNAP. So I want to know what type of outcomes you're to anticipate, or what outcomes are you seeing based on the data you collected? Because I'm seeing some rather alarming issues, concerns, and through our Medicaid Oversight Board on the outcomes and how we're spending our money and the payback we're getting in terms of having people having a healthier lifestyle.
Sure. So thank you. So from a research perspective, we rely on the universities oftentimes to use the access to the data to do research and kind of give us information back. And so KHIE does it for injury prevention, but there are other parts of the university who do other types of research. With regard to the questions about healthy lifestyles and the investments we make, I believe DCBS spoke at a hearing. I don't know that it was this committee, it was a different committee, and gave a presentation recently on the SNAP program where they talked about the evidence of people who are food insecure, people who go hungry, domestic violence increases, child abuse increases, the strain and the stress in the home increases. And so those investments in SNAP are really important. We have about a little over 290,000 families on SNAP, 550 to 600,000 individuals. Nationwide, it's 1 in 8 Americans are on the SNAP program. In Kentucky, it's probably a little bit higher. And so I think we do have, I'm not prepared from off the cuff to recite the specific data, but I think we do have evidence that people's healthcare costs go up, their illnesses worsen, and their ability to function and perform well in the household with their family and at work diminish when they're food insecure and they go hungry. So I think the SNAP program is really important. With the Medicaid data, there's a lot of complexity in there. The Medicaid portion of the CHFS budget is about $20 billion, a little over $20 billion out of the $24 billion. And so in that, we've seen over the years, and again, I'm using aggregate data here, kind of big picture because, off the cuff, we have seen our health rankings nationwide go from 47 to 41 over the last 5 to 7 years, and that's America's health rankings. There's a lot of things that go into that, so let me please be clear. I don't want to oversimplify this. But a really big part of it is people without health insurance live sicker and die younger. And so in our state, which is historically one of the socioeconomically most impoverished states in the country, access to health insurance and access, therefore, to health care has been a challenge. And I appreciate there are different perspectives on Medicaid and its role, but in Kentucky, 1 in 3 Kentuckians are on the Medicaid program. That access to health care has enabled them, I think, to be able to be more productive and engaged in society, and therefore show up at work and do the things that they need to do. So I think and then the Connect platform, we had, forgive me, it's 95,000, give or take a couple thousand people who signed up for commercial health insurance on the Connect platform in the last open enrollment period. So that's really important. Having access to health insurance and health care does not make you healthy, Representative Fleming. I want to be very clear, I understand that distinction. But not having access to it definitely makes you sicker over time. And so for the health and wellness, I would say our approach has been, in part, the Our Healthy Kentucky Home campaign that we've been doing this past year, I think aligns very much with the spirit and intent of the MAHA activities, which are eat fruits and vegetables every day, exercise and be physically active every week, and be socially connected and engaged. And by that, I specifically mean not with these doggone things, because there's all sorts of people, and you're all on social media because your job requires it, all sorts of people arguing with each other and calling each other names and being hateful and spiteful all the time with strangers they never met. We need to get away from this stuff and our computers and sit around a table with each other over a hamburger, a soft drink or a beer, be out in the backyard. We need to get back to some of the old stuff that we used to do, where people actually knew each other as neighbors and not just as hateful, spiteful people that are calling each other names. And so I think on the topic I think you were getting towards, which is the what are we going to do to make people healthier, to go upstream and eat better and be more active and be better social engaged, absolutely fully committed to that as a priority, because we would do far better to prevent poor health than we would be to try to restore it later at much higher cost.
In one example, how would you achieve that?
Well, I do think that we need to look at our food system. I agree with parts of that. We have really highly refined foods. And if you look, again, I hope I try to come across trying to understand the different perspectives. If you go to a grocery store, you should shop around the perimeter, because all the fresh stuff is around the edges. All the fruits and vegetables and the meat and the poultry and the dairy, it's all around the edges. But the cheapest stuff is down the aisles. And the most calories per dollar is down the aisles. So if you're someone on a limited budget and you're hungry, it's cheaper to go to McDonald's. I shouldn't use a specific corporate name, I apologize. It's cheaper to go to fast food and get a fast food meal for $9, or you get a huge beverage laden with sugars and processed foods, saturated and horrible fats. It's a lot cheaper to go there and get a filling meal than it is to go shop fruits and vegetables and take it home and have to prepare it and cook it. And fresh stuff is more expensive. So I think we need to find a way to think, how do we re-engineer our lived environment? How do we make it that the choices that are healthier are the choices that are more preferable in your daily life? Another thing is we built a world where we all rely on getting in cars all the time to go everywhere. We haven't built communities where people can just walk down the street to the grocery store and do simple activities. So, I go on walks. I went with my daughter on a walk last night for 2.3 miles around our neighborhood. I try to practice what I preach and encourage us all to do those things that we've been advocating for Our Healthy Kentucky Home, to eat, exercise, and be socially engaged. And I look forward to participating in these other committees and ongoing dialogue, Representative.
Yeah, thank you.
Okay, thank you. Senator Nemes.
Thank you, Madam Chair. And thank you, Secretary and Commissioner, because your cabinet is so large, it's really hard to handle, and you do so much good. And thanks for the data centers and this and that you're going to help with the cancer research, epidemics, medications, illnesses, and on and on. But I want to know how you're going to stay in your lane, because everything, what's your responsibilities? Everything affects health. You can't do everything. For instance, guns, sure, if you get shot, that's a health problem. But is that your responsibility? Auto accidents. You're in an auto accident. That's health. Are you going to start running the speed limits in the roads? If the roads are messed up, my back hurts. What about your athletic injuries? Are you going to get into the athletics? Do you know your lane? And by the way, love to have you out for a picnic.
I'll comment on that first. You know, in learning and understanding a larger role, particularly in public health, prevent, promote, protect. And so as we think about those and we think about lanes, I think one of the challenges we have is sometimes we stay in our own lane when we should be collaborating with other lanes. And so I appreciate your question, your position that we don't want to step on each other. But I do think there's an opportunity for us to collaborate much more effectively than we have.
And then adding to that, most of our work is very clearly, I shouldn't say clearly, it's clear as mud sometimes, but I mean, it's pretty clearly statutorily defined. I mean, what our roles and responsibilities are for a lot of these programs. And so a part of my job as a commissioner and now as a secretary has been to have to acknowledge that people have legitimate concerns and things they want to work on, but it may not be our particular area that we can be immersively engaged in. So I agree with what Dr. Langfeld said. And one of the things I think we tried real hard to do in my role as commissioner, and I'm going to try to expand it with the secretary's role, is how we work in partnership with others. Because if we uplift others who are already doing good work, they can be celebrated for their good work. Doesn't mean we have to be the ones who do all that stuff. And let's just all be honest and acknowledge with each other as we go into the next budget cycle that's coming up, and with the changes that are happening federally, we're not going to be in an era of abundance in the next couple of years that maybe we've enjoyed the past few years. And so we're all going to have to be thoughtful and make hard choices. And I'll do my best to advise you on those programs and services that give our Kentuckians the very best chance they can have to reach their full potential and thrive. Because I know whether we always agree on the way we get there, I think we're all committed to wanting to make sure Kentuckians have the best chance to succeed in life.
Okay, thank you. We have two more questions, and then we're going to move on. We have a couple more presentations. Senator Douglas.
Thank you very much, Madam Chair. And first of all, I want to congratulate you, Mr. Secretary, and you, Mr. Commissioner, on your new positions. I'm sure you will serve the Commonwealth very, very well, given how you've performed in the past. But I just want to, and I'll try to do this quickly, touch base on some things that were said a little bit earlier. We talked about how data gives us connection. And as elected or appointed officials, we do look at those connections, but we have to look at them in a very, very objective way. My question is this: what does the data tell you about what we should expect from those who are actually receiving the care? And let me put some guardrails around that before you answer that particular question. I know that you would acknowledge, or certainly have heard, that 60 to 70% of our healthcare outcomes are actually patient-driven. They're not driven by our healthcare system, and they're not even driven by the things that we offer in our healthcare. Yet we spend tons of money trying to improve our healthcare system when we are about 30% of the issue. We produce a lot of really, really good information, and I really respect our tertiary care centers who do a wonderful job here in the Commonwealth. Wonderful job. And even our regional universities in their research produce a lot of really, really good data. But in the healthcare space, we have very, very low expectations of those people who are receiving the care. And I think everybody in this room would acknowledge that. We also have a lot of really, really good academic conversations. But my concern is, now being in the legislature, and as you know, being in healthcare for 40 years myself, we actually have very few conversations about real world issues in terms of how do we really address this. So I know our data is objective. We know the real world is emotional. So my question is, how do we tie in the expectations that we have and the requirements that we would expect from those who are receiving the care and who have the greatest influence on our healthcare outcomes? Has that? I'm just asking this as sort of as a conversation starter.
Yeah. Well, thank you for your comments, and I really appreciate your perspective because I think you're exactly right. One of the things that we have to acknowledge is most of our lives are not spent in the healthcare system. It's spent out in the communities. And as we think about the things that really influence and then impact us, it's not within the healthcare system. And as you mentioned, it's been shown that the actual outcomes are not always related to the fact we do more testing or that we do more treatments. And I think the primary objective, certainly in public health, is how do we move upstream? How do we understand the things that are truly driving ultimate outcomes? And I appreciate the fact that finally I think we're coming to recognize that those social drivers that we know, when we're out in the community, there are many touch points. And we could name a lot of them, but there's a whole constellation. And every interaction at any one of those touch points does what? It generates data. The challenge is that most of the time it's not shared across those touch points. So to your point, one of your points, I think, is that we can't find and we can't see the whole picture yet. That's why I think our opportunity and challenge is how do we identify how to collect effectively some of those data points that can help us inform not only how to respond and support in the community, but to help direct as it relates to your all's decisions around policy. So thank you for that comment.
Thank you.
Thank you, Madam Chair.
Of course. Representative Sharp.
Thank you, Madam Chair. Gentlemen, you got a lot of work to do ahead of you, and I appreciate you guys being here, and congratulations on your new positions. But I want to go back to piggyback off a little bit of what Senator Nemes was saying, and it was about the collection on the gun violence. Within the last 48 months in eastern Kentucky, we had a woman that was in her business, which was closed, and she was attacked by an assailant with an edged weapon who was much bigger than she was. She was able to lock herself in her office. The guy busted down a door. She pulled out a weapon, shot, and killed him. How would that be reflected in your database?
Yeah, so first of all, there's not a database per se that all this sits in. KHIE deals with data in transit. So what I mean by that is there are electronic health records that have data. There may be a registry that has data. What KHIE does is it enables connections. The data goes from one place to another, and then when it's at the destination, then a researcher or someone or a clinician could make use of that data for the allowed purposes. So the state is not sitting in possession of all of this data, just to be very clear about that. So what could be done? Someone could look, like a researcher with appropriate access could query, how many times has a hospital emergency department coded a gunshot wound in Kentucky, or a knife wound in Kentucky, or a motor vehicle collision in Kentucky. They could cross-link that with how many times have any of those things occurred and alcohol was involved, like there was a diagnosis of intoxication, or that there was a coding of opioid intoxication. So you can search for these codes, and this is where talented researchers who are properly trained are so important, is they have to frame questions that hopefully, to the best of their ability, achieve clarity about what is a true cause and effect, not just what is a bunch of data points. And so we rely, again, the cabinet itself does not do this kind of research. We're in the business of implementing and executing programs that federal or state law give us resources and a dictate to do. But researchers with access to that data can frame and ask these questions. And it's not perfect, but it can be very good. And if you cross-link it with other data systems, like, well, so what is the average cost of a discharge from a hospital stay if you were admitted with the primary diagnosis of a gunshot wound? Then you could make, estimations about what is the typical cost for a hospital visit if you are admitted specifically for a gunshot wound. And then you could look at how many gunshot wounds we have and what percent are admitted. And that's how they'd start building a structure to come up with an estimate. But there are people who devote their whole lives to having the knowledge and expertise to do that properly, and we rely on them, to support that kind of work.
And I agree with collecting the data, because that'll give us a snapshot of what's going on. But the data's got to be accurate. And
Yes.
that's my question in this. Thank you, Madam Chair.
Yes, thank you. Thank you again for coming back up to the table. We do have a lot of interest in this area, and I agree that with the point that when we're looking at data, it's very important to have those experts help us really analyze it and find a way to make sense of it. So hopefully we're headed in that direction, and I'm sure it won't be the last time that we talk about this topic. Thanks again for being here. Next, I'd like to invite Emily Beauregard and Allison Adams to the table to talk about some of the other health data platforms that are available and how they see improving access and linkage to that data. So thank you very much for being here. Introduce yourselves for the record and go ahead with your presentation.
Good morning, Representative Moser and members of the Health Services Committee. I'm Allison Adams, President and CEO of the Foundation for a Healthy Kentucky. I appreciate the opportunity and the invitation to come here to speak with you today and kind of wrap up all the information that you've heard regarding Kentucky's data sets, access to data, what are we using the data for. You've heard a lot about what data we are collecting, and I'm here to talk to you about in support of a comprehensive health data utility for Kentucky. A utility would essentially be a platform in which you've kind of heard, like, what do we do with all this data? Where's the interoperability of the data? How do we analyze it? Who are our partners? With the sole goal of providing you as members of the legislators what are the best course of actions when we're trying to improve the health outcomes of Kentucky. One of our pieces of the mission with the Foundation for Healthy Kentucky and why we're interested in helping you shape policy that improves and addresses the unmet health needs of Kentucky. And so our only interest here today is to support a well-operated, with a good governance structure, a health data utility to simply give you access, you as a legislature, to validated information that guides you to data-driven action. I'm hearing today with some of your questions that if there was a tool you could have that would validate and prioritize funding requests and actions that maximize our available healthcare dollars and truly improve the health of our population, I think you would want to have it, and I'm hearing that you would want to use it. Though we've had heard some testimony on the promise of RADAR, as it stands right now, Kentucky collects vast amount of data, but the data sets are incomplete, silo, and more importantly, they lack the investment in the needed evaluation and the analysis. As a result, many of our most promising and innovative efforts lack evidence needed to highlight the successes, track progress, and to make the case for scaling what works. Year after year, Kentucky launches new programs or continues to fund existing programs. We test new theories and we adjust healthcare payments while proposed bills aim to have health impact pass and fail. Yet the true impact of these actions and inactions remain a mystery. It's lost in the silence of our disconnected data. Without a comprehensive health data utility to rely upon to evaluate and learn, progress becomes guesswork, as you've already heard, and the cycle repeats, and our poor health outcomes in Kentucky persist. Currently, the health data that the legislature must rely upon is siloed and fragmented. Again, nothing new that you haven't heard already today. The available and collected data is incomplete, it's hard to interpret, and generally is out of reach of you as policymakers, researchers, and the public. In the end, Kentucky is left with the healthcare system guided not by evidence, but by tradition, assumptions, guessworks. And because you don't have usable access to all the information generated in our health ecosystem. And I refer to the health ecosystem. I think it was Representative Fleming and Senator Douglas, you're talking about everything that the patient or the Kentuckian encounters inside and outside the healthcare system, like food access. A comprehensive health data utility that also could include claims data. We haven't heard much about a data point in claims data from both public and private payers changes the ability to have a full, complete picture of what's happening in our health ecosystem. With state policymakers and your staff as the primary users, it could assist you in making smarter, more targeted decisions to improve the health of our state. We've also talked about this morning. Amid the mounting fiscal pressures and an urgent need to optimize our health delivery return on investment, leveraging this kind of data in this way offers a path to transparency. It's illuminating how private and public healthcare dollars are allocated and spent, and which interventions are proven to drive the greatest change. Just as importantly, it can also expose the true cost of doing nothing. A health data utility could also provide you with large sample size, broad geographic coverage, and longitudinal data that follows patients through the health ecosystem over time and in and out of payer systems. It also allows you to harness the existing data and use it better or wisely. I want to be clear to this committee and to our audience. This is, for us, it's not just about collecting more data. It's a request for a smarter approach. We want you to commission a tool that makes the most of existing data and helps drive the contribution of missing information, harness all the databases that currently exist, and then ultimately, when it's analyzed, empowers better evidence-based policy decisions. A comprehensive health data utility could, and I would argue should, be used to track quality metrics by payer, provider, region, and/or population. Support consumer tools that let people compare healthcare service cost and quality. And we have examples of our neighboring state to the north who has a claim data powered website that is information readily available for your constituents and you as policymakers on what's being spent in and out of the healthcare system. You can also use it to analyze cost drivers and identify inefficiencies, like our neighbors to the far west, Colorado, which has used their information to reveal $134 million of unnecessary services. This is not the first time I've been at this table to talk about the missing data piece on claims, what's being paid in the system. And I understand that compelling the submission of claims data may be new for Kentucky, and I recognize that could raise some concerns about data access and usage, privacy, and cost. But Kentucky would not be an early adopter. Today, 23 states have authorized claims data submission, including many models that we can learn from. Your colleagues in these states have addressed these concerns through strict safeguards written in statute and regulations. In summary, and in the interest of time, health data utilities are important resources because they provide access to validated data that can be used for policy decision-making purposes and target community intervention, Senator Douglas. It won't fix everything, but it can give you the information needed to fix what's broken. And most importantly, it can guide you to know where to begin. We can't be everything to everyone. I appreciate the challenges the members of this committee will have going forward in dealing with Kentucky's health issues, especially in light of the anticipated Medicaid cuts and reduction in the available dollars that we use to fund programs within our current health ecosystem. In the coming years, you no doubt will have more requests than resources. That's why creating the Kentucky Health Data Utility isn't just helpful, it's an indispensable tool for you. It is and could be the most powerful tool you could have at your disposal to navigate the complexities of our healthcare system, allocate wisely, and deliver your responsibilities with the confidence and clarity. With better healthcare data infrastructure and interpretive partners like our universities, Kentucky can stop making policy decisions based on guesswork and start acting on evidence. And that would be a win for Kentucky and all of our local communities. And I also want to close in just, in addition to helping establish a Kentucky legislated health data utility, our foundation could also support the data analysis and bring together a dedicated team of stakeholders, working with you, all committed to delivering a clear, actionable roadmap for sound healthcare policy that puts Kentucky on a better path to better health outcomes. Thank you for your time, and I'm appreciative to be here at the table with Emily Beauregard, and we are especially grateful to consider the critical and transformative legislative step toward a healthier Kentucky.
Hi, good morning, everyone. I'm Emily Beauregard. I'm the Executive Director of Kentucky Voices for Health, and I'm really pleased to be here with you today. Thank you, Chair Mosier and members of the committee for inviting us to be part of this discussion about leveraging health data. It is really exciting to hear about all of the efforts underway now and to think about the potential that we could be tapping into by using all of these data sources and having that connective tissue to bring this data together in one centralized way that we could be really mining for more valuable information that you can use to inform policy. At the end of the day, we are all healthcare consumers and taxpayers, and we deserve quality care at a fair price. And I just want to echo what Allison said about the need for better informed decisions, particularly as you move into a budget session and looking at some of these federal cuts and changes to programs that will require really understanding where we're making the most impact, where we have more opportunity, and where there may be waste in the system that we could redirect to better patient care. As a coalition led by Consumer Voices, we hear regularly from Kentuckians who have coverage and still struggle to get the care they need. And their experiences reflect the same frustrations and challenges members of this committee have voiced at different times. The cost of care keeps rising while outcomes are mixed. It's hard to find an in-network provider, especially for mental health and dental care. Paperwork keeps increasing. And one we hear a lot in this committee, we have plenty of data, it's just not getting used. In fact, one of the points we've heard from hospitals in the past is that this data already exists, and that's true. I think you've heard that today over and over. The problem is that it is incredibly fragmented, and none of us have all the pieces. A health data utility, as Allison outlined, really brings those pieces together in a uniform way for apples-to-apples comparison. The core buckets include administrative, clinical, social, and public health data. And I've included some concrete examples of what types of data fall into those buckets. This is by no means exhaustive, but these are type data sets that we have here in Kentucky. And what you can see on the top right of the screen are all of the data sets that our executive branch has now. I shouldn't say all, some of the data sets. Truly, it is substantial. And there's already a lot of work being done, as you heard with KHIE, to integrate or to at least create that connective tissue. But there's also more opportunity to really focus on integrating and creating that centralized repository. And then you can see in the middle some of those data sets that we're missing. And some of these could be optional, particularly with our commercial insurers. But what I want to bring your attention to are the data sources that we could be doing a lot more with. We just heard Secretary Stack and Commissioner Langfield talk about all the ways that KHIE has evolved over the years to be this incredible information highway with that connective tissue between different systems. We want to see that continue with the collection of more clinical screening and referral data all in the same place, because that would be the key to understanding the drivers of poor health and what interventions are making the most impact across health systems, across regions, and insurers. And another untapped resource in our state is our state university partnerships. These support research that use Kentucky Medicaid data to understand more about the populations being served and how Medicaid itself is administered. Two current studies that I happen to be familiar with are focused on perinatal care and network adequacy. And these are both topics that this committee has taken up and worked on pretty extensively to improve over the years. And there are many more. I'd really love to see the findings of those studies presented regularly at legislative committees and used more intentionally to inform policy and practice. Now, pulling the right data sets together is only part of the solution. We've heard a lot about a lot of this data today. What we haven't talked much about is longitudinal data, data over time, to really tell that story of health through the lifespan. If you think about it, so much of our care is episodic, and most of us change insurers every few years, if not yearly, which means that there's no longitudinal record of our care through the lifespan. So in this scenario, we have a state employee with benefits. They stay with the state, work with the state for about 10 years, lose their job one day, and they're able to enroll in Medicaid, and that helps to support their health as they get back on their feet. After a few months, they're able to start a business. And as their income increases, they are able to transition from Medicaid to a marketplace plan. After about a year, open enrollment comes around, they shop, they find a plan that's better suited to them, and they switch. And then they stay in that plan until they turn 65, retire, and are covered by Medicare. Now, they maintain insurance this entire time. They never go uninsured. But depending on the health plan, their experience utilizing the healthcare system varies greatly in terms of which providers are in network, how much they pay in out-of-pocket cost, and how easy or hard it is to get a prior authorization approved. So by connecting these records together, we can suddenly see how cost, access to care, and health outcomes change over time. And as we integrate this data, we can start to answer questions and hone in on care gaps, on workforce shortages, and health-related social needs that can help policymakers and providers make more strategic decisions. Here are just a few of the data sets that can help to paint that picture. We know that our licensure data is incomplete. Adding in paid claims can fill in the gaps by telling us how many OBGYNs are actually billing for services in Anderson County, which happens to be a maternal care desert. It can also tell us how many Anderson County residents are traveling to other counties for their care and where they're going. And by adding in prior authorization data, we can start to see how PAs impact patient care, medication adherence, paperwork, and even provider productivity. And along those lines, we can use a health data utility to identify waste. And I don't mean waste in the form of something intentional, I mean inefficiencies, which can come in the form of clinical waste, like unnecessary services, operational waste, like not sharing test results, or administrative waste, like billing errors and prior authorization delays. But together, and this always astounds me, wasted spending accounts for nearly a quarter of total spending. Now, I don't mean to suggest that those dollars are dollars we can do without. I think those are dollars that we should be redirecting. We could be redirecting them to build a stronger healthcare workforce, to make up for Medicaid cuts, to keep expanding our home and community-based service waiver slots, and to fund nurses and mental health providers in every school. But whatever those priorities may be, we're going to need a data-driven, scalpel approach to achieve them so that we're not compromising coverage or access to high-quality care. And I know that this was all a very quick and high-level overview of a health data utility and what some of those uses could be, but there's a lot of potential here, and I hope this gave you some new perspective on how we could be and should be leveraging our data to improve the health of Kentuckians. We're happy to answer any questions.
Okay, thank you so much, and I really appreciate your efficient use of time. So sorry we are running long again, but we really appreciate your input and your suggestions. And we do have one question, Representative Camuel.
Thank you, Madam Chair, and my apologies for being late today. I am here. I appreciate what you were saying about efficiencies and looking at network adequacy and such, and it brought to mind, and I'll just make this point briefly, there's a book, a Lemony Snicket book, 5th grade level, called The Inhospitable Hospital, and it talks about repeatedly the most important thing done in a hospital is paperwork, and I like it's so inefficient. So I appreciate you looking at that and bringing that up. But one of my questions is for network adequacy, do you have an example on how more uniformly collected data could translate into improve the network adequacy?
Yes, we have been working on network adequacy for a number of years. And when you look at statute and regulation, we have strong network adequacy rules. They are not enforced in ways that I think are very effective. But that's partly because the way that we measure network adequacy is relatively crude and simple. It is how many providers do you have in your network in this particular area? And that doesn't get to how many services are being billed in that area. How many patients are you actually seeing? So you can participate in any number of health plans, but you may only see 1 or 2 patients that have that health insurance. We see that often with Medicaid managed care. You know, providers will participate in all 5, but will often have to choose to limit how many Medicaid members they may see on any given day, to make sure that their payer mix works for them. And you can also see that in just, how busy a provider is and if they're taking new patients or not. So there's no sense in counting a provider as, being a full FTE capacity when they're not taking new patients. Or perhaps they may even not be actively practicing in a clinical setting. They could be working at a university administratively. They could be retired or part-time. And this is information that we aren't collecting now. Part of that is a licensure data issue, and I know that that's work that Chair Mosier has been doing. But this is also something that we could be doing by looking at claims data to see what is the volume of services being provided by any given provider.
Thank you. That was very thorough. I really appreciate it. May I ask just a quick follow-up on this?
We are out of time.
Okay.
Yeah.
Okay. Thank you.
Can it wait?
Yeah, it's just about accessibility. Will this improve accessibility in rural communities? So we can follow up.
All right. Thanks. Quickly, Representative Wilner.
And I know we're so pushed for time here, but we heard the statistics about personal responsibility and individual decisions we make. And I think all of that is true, of course, but as health policy makers, what I hear consistently is that the number one contributor to health outcomes is good health policy. And I just wonder if at a really high level you could just, is that true that the decisions that we make, the policies we pass are going to have a direct impact on Kentuckians' health?
So I heard Secretary Stack say something that is very similar to my mantra, which is to make the healthy choice the easy choice. And we can do that so often in how we design policy, how we build these programs to make them easier for patients to understand and navigate, to make that simple choice. Now, if you're thinking of grocery store shopping, subsidizing fruits and vegetables, making them less expensive so that, it is a more rational decision for someone on a tight budget. So, yes, I think that is absolutely the power of policy. And that's why I work in policy every day, because I see that opportunity and potential in this work.
I think to follow up, Rep. Wilner, if I may, from this committee standpoint, a health and all policy approach, as you go to your colleagues in other committees, like economic development, like the grocer's business, the communities that affect the other pieces of the ecosystem, if we had a broader perspective of what each committee has, what their impact is on health, then we're working together. So not just looking at it from a health services committee perspective, but what is it across all levels and all committees of government.
Okay. All right. Thank you so much. Great food for thought. And not the last time we're going to talk about this. So thank you for being here. Okay, next, we have a lot of regs that we need to review. What I would like to do is jump to those regs and pull out 201 KAR 005010. That is the optometric examiners reg, and consider all of the rest. Does that make sense to everyone? Okay, did everyone on the committee have a chance to review the regulations? Okay, are there any questions or discussion? Okay, all right. Well, if not, I will consider that all of those regulations are reviewed. I have pulled out 201 KAR 005010, and I would like to, at this time, invite to the table for a discussion of the optometry regulation. Dr. Jill Bryant, Dr. Michael Olson, Christy Lee May, and Dr. Joe Ellis, please. If you can make your way to the table, you each have 5 minutes to present your side of the debate, if you will. And I think it would actually be good if we had everyone at the table, because all of the questions are probably going to be answerable by all of you. And I'm sorry for the short amount of time, but we are always trying to cover a lot of information. And I think I'd like to invite the Kentucky Board of Optometric Examiners to go first, since this is your proposed regulation. Welcome. Please introduce yourselves for the record. State your name, and I'll have everyone state your name first and then proceed.
Yes, thank you, Madam Chair, Moser, and the committee. My name is Dr. Joe Ellis. I'm from Benton, Kentucky. I actually live in Benton, Kentucky, and practiced there since 1986. I'm currently the president of the Kentucky Board of Optometric Examiners. Beside me is Christy LeMay. She's our executive director of this Board of Examiners. Couple of things, just a few comments here to kind of clarify the differences in the boards we have available for optometry. We have
if you could please just allow everyone at the table to introduce themselves first,
Okay.
and then we'll proceed. Thank
Okay.
you.
Hi, I'm Dr. Michael Olson. I'm the current president of the National Board of Examiners in Optometry.
Good morning. I'm Dr. Jill Bryant. I'm the executive director of the National Board of Examiners in Optometry.
Okay. So committee, just a few comments here about the difference in structure, the content, and really the philosophy, because this is mainly an issue about philosophy of how you administer boards. The Kentucky Board of Optometric Examiners is tasked with making sure that optometrists entering the Commonwealth are clinically competent and also make sure they're properly credentialed. Also, our state currently has some of the strictest regulations in all the states. Actually, 36 different state boards of optometry, if they migrate to our state, have to have other coursework before they'll sit before this Board of Examiners. That's 36 states. And also, we do monitor the schools of optometry. There's 2 schools of optometry that we monitor all the curriculum and clinical background, and we require these 2 schools to give us more coursework before they can sit before the board. So again, we are one of the strictest ones out in the whole country. Also, we feel like it's our obligation to continually look at accreditation, board scores, these type of things. But you've already heard today about data, artificial intelligence in healthcare, so we need to be always looking for different avenues and to make sure our students coming in here, licensees, are clinically relevant. The National Board of Examiners here is a testing organization. They're actually the only one we have nationally here. Also, they have no statutory regulatory authority in any district at all. But a couple of things. What brought this to our attention was, luckily in the Commonwealth, especially in Lexington and Louisville, we have some centers of excellence for eye care, and we have people who come from all over the country to do externships, the 4th year in optometry school, in our centers of excellence in Lexington and Louisville. We also have some that want to stay here for residencies. They came to us and said they had already passed Canadian Boards Part 1, and would we accept it in lieu of the National Board Part 1? We never even thought about it until we got these questions from some of these people potentially being in a residency program. Obviously, people who are doing a residency program are very clinically astute, and so hopefully they would maybe stay in the Commonwealth. So we never thought about it until we just asked the question and we started looking. So again, once our research showed us that it's a different format, different structure, we felt like it did not impact the safety of Kentuckians at all. And actually, it was probably more testing more clinical competency than currently what we had. So this combination we're discussing here, I doubt if few people take this because it's actually more rigorous. The Canadian Part 1, they still have to take the national boards from our colleagues here, Part 2 and 3. But again, it is more clinically competent. Now, a couple of things. We also found that the accreditation of colleges in optometry, they look at both boards, the Canadian boards, the U.S. boards, to make sure the colleges are still accredited. We also reached out to other states that are looking into different alternative pathways too, and we've got a couple, Oklahoma and Louisiana are looking into this same pathway. Again, we have sent you information about a side-by-side comparison, topic by topic comparison, and you can see they're very similar. The difference is philosophical. The National Board Part 1 is more discipline academic based, where the Canadian Board Part 1 is more clinically competency based. Give you a quick example. Part 1 requires a lot of memorization. It might be an optics questions you fill out. The Canadian Board is a different type of testing strategy. They use basic science and they implement it into clinical competency. For example, a 68-year-old diabetic patient may have blurred vision. The next question would be different differential diagnosis, different testing, etc. So again, more clinically competency. So again, in the future, especially with AI and these other changes, we need to be looking for people who have a background in basic science, but more importantly, they have a good clinical competency base. So again, thank you for your attention to this matter.
Thank you so much.
Do we need to switch places?
Okay.
I'll take my book, Joe.
Okay.
Yeah, that's probably better. I'm incompetent.
Thank you.
As soon as we decide where we're going to sit.
Please proceed.
Can you hear me okay?
We can hear you fine.
I'm going to ad lib. We have some just short remarks to read too for the record, but I do want to ad lib a bit because your presentations today were unbelievably good. And I actually practice in a rural hospital in Minnesota. And the senator who mentioned COVID, I thought I'd just mention this textbook is a new one on the basic sciences. This is not the stuff covered on Part 2 or the Canada written Part 1. It's for ophthalmology and optometry. And actually the newest chapter is COVID, which I just thought was fascinating. And if you look at the mechanisms of immunization, human development, pregnancy, neuroanatomy, microbiology, and pediatrics, that's all Part 1 of the National Board. It's not 2 or 3. I came from Iowa, which is a cancer hotspot, and when we test anatomy, we test that for very good reasons. That's Part 1. Breast cancer and lung cancer from the apex of the lung often shows up in the eye. It metastasizes to the eye. When your presentations spoke of data, scientific research, exponential growth in medical information, that kind of knowledge is why physicians have step 1 and test basic sciences, and why doctors of optometry have step 1 or part 1 testing the basic sciences. It assures a level of competency across the nation. That's why these things were formed, such as medicine, pharmacy, nursing, all have a part 1. and it's for the public safety. It's a level of knowledge and skill. As we go to another senator's remarks on the ER, when you saw ER cases, they were complex cases. And mastery of the basic sciences is associated, I'm not lecturing you, you already know this, associated with better outcomes in complex cases. I was a rural optometrist seeing nursing home patients and going to the ER and sadly saw a lot of complex cases. And so the reason there is a Part 1 of National Board since 1951 is to assure that doctors of optometry have this knowledge and skill. And then another representative said about good policy. In 2024, a person named Albert published a systematic review of the importance of basic science to clinical relevance and outcomes. And he found that you have increased diagnostic accuracy, increased outcomes in unexpected cases, and increased integration of new information over time. In other words, lifelong learning. And that's really why we test basic science in optometry, why medicine has a step 1 in basic science before they move on. And that's really why we're here.
Okay. Thank you so much. I know that we have a few questions. And
She has some things
okay.
to read though here
sure.
too. Yeah.
All righty.
I know you're hurried for time. We're trying to hurry.
Thank you, Chair Moser. So I'm just going to skip ahead a bit in the slides to talk about our exam series. So in the United States, MBO provides a 3-part exam series, and this is based upon research and data collected from across the entire optometric profession, and it's based upon the scope of practice for optometry in the United States. In contrast, the Optometry Examining Board of Canada, or the OEBC, administers a 2-part exam series for licensure, and this is based upon their research designed for the more restricted Canadian scope of practice. Each part of the MBO exam is necessary because we are measuring different competencies in an overall assessment of readiness to enter into the independent practice of optometry. So in comparing the American and the Canadian exams, there is no Canadian version of Part 1 of the National Board. However, there are Canadian counterparts to Part 2 and Part 3, although those are also designed for and have been validated only for this limited scope of practice and not for U.S. optometry. The Kentucky Board wants to allow substitution of the American Part 1 with the Canadian written exam, which would eliminate biomedical science testing that Dr. Olson was just referring to. MBO Part 1 requires exam takers to really understand the why and the how behind clinical applications. It tests the foundational knowledge that explains mechanisms behind tissue interactions, the science behind the disease process, and how medications are specifically working. Patients present to the optometrist's office every day with disease conditions that do not look like the pictures in the textbook. To treat that patient, optometrists must go back to their basic science knowledge, think through it, and apply that knowledge to the situation. This is essential for doctors of optometry to be able to appropriately care for patients. The Kentucky Board argues that ACOE school accreditation has a bearing on whether the Canadian exam is equivalent to MBO. Not so. Regardless of educational preparation, if optometry candidates are unable to pass Part 1, that shows that they have not gained the biomedical knowledge needed for independent optometric practice. So to break this down further, we can look at the actual competency domains that are tested on both exams, and we do see real differences. MBO Part 1 is grounded in the foundational biomedical sciences essential to proper clinical care and patient outcomes. The Canadian exam does not cover that same content knowledge. In fact, a 2022 paper published in the Canadian Journal of Optometry concluded that while both exams were appropriate for their respective jurisdictions, they were not equivalent. This conclusion was supported by a majority of Canadian regulators surveyed. And there's another important difference. The MBO Part 1 is delivered in a secure, live proctored professional testing environment. The Canadian exam is delivered online through remote proctoring. Research shows exam security risks increase up to 7 times for remote proctored exams. I do want to emphasize, every question on the MBO Part 1 has a direct tie to clinical care and to patient outcomes. So here's an example. This is a real question from Part 1 that has now been retired from the active question data bank. And in this question, test takers are being asked to understand the most common bacteria that is present on human skin. This photo shows an optometrist performing a lid biopsy, which Kentucky optometrists are allowed to perform. Patients in Kentucky need their optometrist to understand the types of infections that can occur when performing this procedure. Testing of the basic sciences in a licensure exam series is not unique to optometry. Other U.S. doctoral level health professions test basic science as well. This includes medicine, podiatry, chiropractic medicine, and dentistry. Eliminating this requirement is inconsistent with the responsibilities of the profession. So in conclusion, the proposed regulatory amendment before you lowers the standards for optometric licensure, and it puts patient care at risk. Kentucky patients deserve optometrists who meet the same standards as every other state in this nation. Licensure should be about competency and not about convenience. Licensure standards matter. They matter to public protection, and they matter to protecting the people of Kentucky. This amendment does not meet the standards needed to license optometrists. Please find the amendment deficient. Thank you.
Thank you very much for your presentation to both of you. This has generated a lot of conversation over the past several months, actually. And I think that there are some real legitimate questions. I am going to just start out before I go to questions and ask the agency, the Kentucky agency, would you be willing to defer this for 90 days to be able to work out the differences that we're, trying to identify? Is that something that you would be amenable to?
We've actually had this regulation out, Madam Chair, probably late fall. And actually, we did speak to the National Board of Examiners. They did come to our last board meeting. We did discuss. But really, I'd have to see my whole board, what they would say. But we feel very confident.
Well, this would give you time to talk to your board. We're not shutting this down. We're not finding it deficient. We're just saying we need a little more time to work on this, to make sure that we are protecting patient safety, that the licensure standards are being held to the standards that I know that you want for Kentucky patients. It's not often that we get so much dialogue, and it's certainly not that common for us to defer a regulation, and we don't want to find it deficient because then we come back with legislation which is probably less helpful to you. So,
okay, all right, we'll be happy to defer if that's the pleasure of this committee.
Okay, so thank you. I appreciate that. And then you'll need to ask for a deferral of the regs, and we'll take a voice vote to affirm that.
All right, the Board of Examiners asks for a deferral of the reg as presented.
Thank you. Yes, we have one question, Senator Carroll.
And Madam Chair, forgive me for butting into this process, but under KRS 32250, we really have no ability to do anything about this. This statute gives the board the entire decision as to what testing to be accepted by the state. So this is an issue that we need to, if we're going to address it, it needs to be addressed during session. And I don't think we have the ability to approve or not approve or question any regulation related to this, as existing statute gives them the authority to do what they're doing.
Thank you, Senator. And in reading the statute, I would agree with that. And but I do believe that there is a question out to the Attorney General's office to confirm that. And this would also give them time to confirm that the statutory authorization exists. Okay. Are there any further questions before we Senator Nemes?
Just for clarity, that if we're asking them to work together, there's nothing for them to compromise on. Either we're going to accept another test or we are not. So to defer it would be for us to make up our mind. So I see no reason to defer it, because one wants the test and one doesn't. There's not going to be any compromise on working together on changing things.
Well, thank you for that point. But some things have come up in the last 24 hours that have thrown a few things into question, and I'd like to give them time to work it out internally, and then, if we need to, we can have another conversation about it.
And I have a question on if we're going to vote on whether we're going to defer this or not. Is that a vote on whether, if you vote no, would we vote right now to do it then?
Well, we would confirm that we are asking, that the agency is asking for a deferral.
So if we vote yes, we're going to defer it. If we vote no, we'll vote now on it.
Right.
Thank you.
Mm-hmm. Okay. Senator Herron.
Thank you. Just so I can have more understanding, if you can just answer a question for me. I think that most medicines, or I know most medicines, all medicines have some type of a national licensure. And so I think that is to ensure that public is protected. And so I guess my question is under this circumstance, why are we wanting to not follow the national licensure process here in Kentucky? Like, why do we want to, what's the purpose of changing that?
Yes, Senator, when we were approached about some people wanting to do residency here, they'd already taken the test, and frankly, they already owe $200,000, $250,000 in education debt. These tests cost $1,400. So we never even thought about looking at the difference in the two, because we were like most state agencies in optometry, we were going to accept the national boards. But we got to looking, and it was kind of intriguing. You have to admit it's somewhat intriguing, because it does take basic science and do clinical competency. So again, that's what perked our interest. Like, well, heck, these are different, but they're different in similar ways with content. So that's what the genesis was.
Quickly.
I think for me, I'm just concerned that all of the states follow this one thing, and it's very concerning that we in Kentucky are going to say we're going to remove ourselves from this process and be the first to do it because of the cost. Maybe I just need more education on it, but I'm a little confused by it.
No, ma'am, it was not so much about the cost factor, but we felt like they were, we have the statutory authority, it says, to accept other similar testing, and that's why we thought they were similar. So we didn't want them to go through the same thing. I will say that I think all medical professions over the next few years are going to go to more clinically competency-based, not so much basic science facts and memorization type things. But it was not cost. It was like we felt like they were similar, and we felt like we had the authority to approve that test when we were approached.
Okay, thank you. I have a couple of questions, but I don't want to keep this going. I don't exactly know why just Canada and not other countries. I don't know how many students this affects. I mean, I'm all for improving our workforce and keeping folks here in Kentucky if we can. I guess I was given a little pause when I heard that Canada doesn't accept our test, but we're asking to accept their test. Can you clarify why that's maybe their position? Maybe I hate to ask you to interpret their position, but
I can't interpret their position, but I will say, and I didn't know this till we did some research. We talked about the American Council on Accreditation of Optometric Education. They credential schools in Canada and also the U.S. On the medical side, up until this past year, their credentialing board of the medical schools credentialed both Canada and the U.S. schools up until this past year. So I guess there's some schism, if you will, between. But up until now, the accreditations board, sanctioned by the Department of Ed, accredited the medical schools in both the U.S. and Canada the same way the American Council on Optometric Ed did for optometry schools,
Yeah.
or still do, I should say.
I know, it's curious.
Yeah.
Do you want to weigh in from the national perspective?
I can try to clarify a little bit. I don't want to go back and forth. I know you're worried about time. In 2022, Canada, the Association of Provincial Regulatory Agencies, put out a study and said the tests are not equivalent. So even from Canada's side, national board is different than Canada. It's a different nation. It's a different healthcare system. It's a different scope of practice. They're clearly just different. It's not a matter of better, worse, up, down. It's different. And traditionally, we do test the basic sciences or the biomedical sciences in medicine, pharmacy, optometry, podiatry, and that's done because of the link to better healthcare, better outcomes. It's what makes doctors doctors.
Right. Okay, this is going to be like speed dating, so I want the questions really fast. Representative Callaway.
I haven't been able to come across exactly where it was, but apparently NBEO was approached about given recommendations based on the positive qualities that they see from the OEBC tests. So has NBEO considered any changes to consider some of the more competency-based?
Good question.
Some of the other things that they had said that they found more positive for their exams.
I'm not exactly sure how to answer your question, but I can try to clarify. The Canada written very closely resembles our Part 2. We have a one exam in 3 parts. So their written does not equate to our Part 1 basic sciences. In fact, even if you look at the OEBC website, it will say to prepare for the written Part 1, look at the NBO Part 2 materials. So they're not the same. I'm not trying to dodge your question. I'm not really familiar with what you're saying. So I was kind of stunned by that. But I don't think there's anything wrong with my friends in Canada or the Canadian system. Their scopes of practice are much different than the United States. Their test is much different. Their healthcare system is very different. So I would just call them 2 different tests. And our test is one test in 3 parts. And the basic sciences are crucial to that. They're not just esoteric questions, what's the speed of light? Each question, each item relates to eye care.
Okay.
Did that help? Or did...
Okay.
Right.
Senator Berg's first. Sorry.
Thank you, Madam Chairwoman. And thank you for a very, very interesting discussion that has a lot to do with what's going on in healthcare these days. A lot to do with it. There are currently more than one way to get certified to practice medicine in the United States. You know that.
Yeah.
You can go through as an MD, you can go through as a DO. There are different pathways to licensure for many, many medical professions. And I myself am not in favor of proprietary pathways because they add to the cost of health care. You all have a proprietary pathway at this point. You consider yourselves the only examiners in the world who are good enough to license people to pass part 1 of the optometry exam. We're not even talking about part 2 and part 3, which we're still giving you. You still will be the only people who can monitor and give that exam. Okay? Why do you not want to give up part 1? What's your thought process?
Okay, I was told to be quick. I was told to be fast, but that's difficult. I don't really feel I'm better than anyone else. I came from rural Iowa. I'm a hick. I now practice in a small rural hospital in my dotage. And as president of the national board, I'm a volunteer. We are not paid. It has nothing to do with money or some sort of great feeling I have about myself or our executive director or any of the rest of us. Medicine does have different pathways because osteopathic medicine was different. It came from a different heritage from a guy named Still, and medicine and osteopathic medicine found a way to work together. So the DOs can now take the US MLE, but it's still a standard. It's one standard, and it's a United States standard. Different healthcare systems still do what they do. ODs are held to the medical standard of care. In Minnesota and Iowa, I'm held to the medical standard of care by law. I have no choice. And so the idea of not assessing the basic sciences for this minimum level of competency in a very mobile world, it does sort of bother me. And I feel very strongly that in my practice, being the only eye doctor for a long way most of the time, and now being the only eye care provider in an entire hospital some days, I really call upon my knowledge in the human body and pharmacology and all those things on a daily basis. And so personally, it's just what I do, Senator. It really doesn't have much more to do with anything than else. I don't think I'm better than anybody.
Okay, Representative Wilner.
Thank you, Madam Chair. I feel like something that's getting lost in this conversation, and the national folks did bring this up, scope of practice. Scope of practice is so important. When I was a kid, optometrists did vision screenings and prescriptions for eyeglasses. Kentucky's scope of practice, at least a few years ago, was the most lenient in the country. It is still at least one of the most lenient. It allows surgery. It allows scalpels to eyes. And the idea of us having this conversation about lowering standards when the scope of practice is so broad, it's a very, I think, dangerous path that we're on here. And I would personally find this reg deficient, but it concerns me that we're talking about lowering the standard, and I have no interest in reducing the scope of practice for optometry. I do not. I think it's great that we've got so many vision experts and providers in the state, but I don't see how we can lower the standard with the expansive scope of practice that we have. And I wonder if the legislature might, if we pass this, allow this to go through, if there might need to be conversations about, is the Kentucky scope of practice appropriate for this new licensure pathway? And my guess is that it's not.
Okay, thank you. we have quorum concerns. If we could just stick around for a couple more minutes to finish this up. Representative Duval.
Thank you for being here, Dr. Bryant. Appreciated prior conversations with you. Thank you for your work, and I want to commend you. You did a tremendous job on parts 2 and parts 3, and those, in my mind, are absolutely the most critical, the most important parts of the national board exams to make sure that Kentucky optometrists are prepared for clinical practice, for assessment, diagnosis, and treatment of ocular disease. And I think you guys do a tremendous job on that. I will say that I do have concerns about part 1, and I guess it's not been said, but national pass rates have been low. And once again, that does not indicate that the test is too difficult. I would say I question some of the relevancy of the test. And I would say that there is a disconnect between what is being tested and what is being taught in optometry schools across the country. So we need to figure that out. We need to figure out why that test rate is so low. So the new reg actually it goes along with statute. The statute already allows the board to make this decision. So the reg simply comes alongside that. So, anyways, that's my comments on the situation. So, yeah.
Thank you. I really appreciate that, and I value your opinion. There was a question about the pass rate. I think the Canadian pass rate is for their part 1 is 95.6% compared to 66.7%. But yeah, did you want to say something? Okay.
If I could respond to the representative, pass rates dropped post-COVID and are actually coming back up. These tests are made by large committees of optometrists familiar with the candidates at the level of training. Over 200 optometrists involved in the creation of this exam. Almost all the colleges are involved in the creation of the exam. It's incredibly relevant. I don't think you would want medicine to discontinue step 1, and I don't think medicine will consider getting rid of step 1. These are critical things to know over the entire career and linked to lifelong learning. And it's all textbook. I have many, many papers. I presented some to your state board here. It's not my opinion. It's factual, sir.
And if I could just add, Representative, every question that's used on Part 1 is reviewed by approximately 25 optometrists before it is implemented on the exam. And when they have discussions about the questions, they take into account, is this clinically relevant? And if it's not used on the exam. So every question that is used on the Part 1 exam is directly related to clinical care. I also wanted to point out, because you were talking about pass rate, and Dr. Olson discussed the trend that we had seen after the pandemic, but we had actually gone back to make sure that our exam was not a problem. And so we have a percentage of items that are used on various forms across years, right? There's new items. There's also some older items that we have statistics on. So we compared 2020 students on the same items as 2022 students. And what we saw was that the 2022 students performed significantly worse. So that told us that the change that we saw in the pass rate was not a reflection of the exam itself, but rather the candidate cohort taking the exam.
Okay, thank you. We're going to have to move on. I'm sorry, Senator Adams. I think you have not had a turn.
Yes, and I thank you, Madam Chair. And in the interest of time, I am going to not ask my question. I know Dr. Ellis really well. Thanks for stirring up every optometrist in the city of Louisville, because I've heard from all of them. But I do know that time is of the essence. But I want to say I really appreciate you for agreeing to just defer this for a little bit I think it just gives the committee members a little bit of time to get comfortable. So thank you for that, and I appreciate you.
Okay. Given that, I would like to ask for a motion to defer for 90 days, please.
Motion.
And a second. Okay. And we will have a roll call.
Senator Rocky Adams, Senator Berg, Senator Carroll.
Madam Chair, I'm going to vote no and like to quickly explain.
Sure.
We don't have the authority to do what we're doing right now. We didn't give it to ourselves, so I'll be a no vote.
Senator Douglas.
Aye.
Senator Herron. Senator Mills. Senator Nemes.
No.
Senator Rawlings. Senator Richardson. Senator Tishner. Representative Bratcher. Representative Bray. Representative Burke. Representative Callaway.
No.
Representative Camuel.
Yes.
Representative Dotson.
No.
Representative Duval.
No.
Representative Fleming. Representative Gordon. Representative Holloway.
I'm going to pass.
Representative Marzian.
I vote yes, and briefly, can I explain my vote? We passed this in administrative regs, and it had been out there about a year with no comments, I think, from the National Board. I felt very comfortable with it, and I still do. So I thank you, Dr. Ellis. And I heard from my local people who said it's basically a turf battle, but the exams are equivalent. Thank you.
So was that a yes or a no? To defer? Okay. All right.
Representative Neighbors.
Yes.
Representative Proctor. Representative Rayburn. Representative Raymer.
Yes.
Representative Riley. Representative Sharp. Representative Wilner.
Yes.
Co-Chair Meredith. Co-Chair Mosier.
Yes. Okay. The motion does pass to defer for 90 days, and I look forward to having further discussions. I really do appreciate all of your work. We just want to get this right, so thank you. Okay. All right. Last, we do have to hear the Unified Community Mental Health and Substance Use Prevention and Treatment Block Grant application. Obviously, I need for you all to be quick, and it's just federally required that we have a hearing on this. So thank you for sticking around.
I'll go ahead and introduce myself.
Yes, if you could turn your microphone on.
I'll go ahead and introduce myself. I am Melissa Runyon, and I am the Block Grant Program Administrator at the Department for Behavioral Health, Developmental, and Intellectual Disabilities.
And I'm Patty Clark. I'm the Director for the Division of Mental Health within the Kentucky Department for Behavioral Health, Developmental, and Intellectual Disabilities.
And I will go as fast as possible, but I'm here to present our block grant application for it's a unified application. We apply for both grants together. Next slide, please. These are non-competitive grants that are given to all 50 states and U.S. territories, and we just have to do the things on this slide in order to receive those funds. We have to, every 2 years, present an application and a plan of what we're going to do, and that's what we're here for right now. We have to provide annual reports every year. We have to complete any revision requests and participate in site visits and reviews. Our block grants can only be used to carry out our plans that get submitted and approved, our evaluation of the programs and services under the plan, and any planning, administering, educational activities that help support providing those services. We must use our block grants for these three things, which is basically to fund priority treatment and recovery support services for people who are uninsured or underinsured. We can fund primary prevention with our substance use block grant, which is helping prevent people from actually getting substance use disorders. And we can collect performance and outcome data for mental health and substance use and recovery services. Our two block grants that we receive are the mental health block grant and the substance use prevention, treatment, and recovery services block grant. We also receive a small amount of funding under the Bipartisan Safer Communities Act as a supplement just to the mental health block grant. So there are restrictive requirements for each one of these grants. They must be used for community-based services. The mental health block grant requires that we serve people with serious mental illness and children with serious emotional disturbance. There's also a 10% set aside for early interventions for first episode psychosis and a 5% set aside for crisis services. There's also minimum expenditure amounts for children's services. There's a maintenance of effort requirement, and there's a cap on administration at 5%. This is the federal definition for serious mental illness, and I'll just let you see that. We'll just keep going. And this is the federal definition for serious emotional disturbances. There are state definitions for both of these things that are a little more restrictive than what is federally, but they pretty much align. That's okay, keep going. For the breakdown, the 25 current amount is listed there. Our maintenance of effort requirement, so that means we must spend certain state funding to meet a certain level in order to continue to qualify for these funds. We also must spend that amount for minimum for children's services in order to continue to qualify. And again, our 10%, our 5%, and no more than 5% of the final award for admin. For the substance use block grant, the requirements, again, it's all community-based services. There's a 20% set aside for, like I was talking about, primary prevention. So these are things delivered prior to the diagnosis of a substance use disorder. There's also a minimum expenditure amount for pregnant women with substance use disorders and women with dependent children. Maintenance of effort requirements there as well as a 5% cap on admin. These are the priority populations for the substance use block grant. I mentioned pregnant women, women with dependent children, persons who inject drugs, persons who are in services for substance use disorders that have or are at risk for tuberculosis, early intervention for HIV or AIDS. Kentucky does not have a high enough AIDS rate to actually be a designated state, but that is one of the required populations. Persons in need of recovery support services for substance use disorder, and then states can pick a priority or other populations, and Kentucky picks the service members, veterans, and their families with substance use disorders. Funding breakdown is that's our 25 amount. There are maintenance of effort. Again, you have to spend a certain amount of state funds to qualify for these. There's the 20% of the total award for primary prevention. That amount that's listed for pregnant women, that is the amount that must be spent in order to meet that standard, and there's a cap of 5% for admin. And then just to talk briefly about the supplemental, this is only for mental health block grant, and this was through the Bipartisan Safer Communities Act that I think came out in 2022. But they're designed for mental health emergencies such as natural or man-made disasters or other mental health emergencies. And we have to focus on individuals with the SED or the SMI. There's also the set aside requirement for that 841,000. 10% must be used for first episode psychosis and 5% for crisis services. And then we are required as a state to list a performance indicator for each of their required populations, things that we're going to measure over the next 2 years. And if you want me to go fast, I can just let you look at those, and if anyone has any questions, but they're in order of each population. And that's it.
Okay, thank you so much. It is a lot of information, but thank you for going quickly, and I appreciate what you're doing. All we need to do is have a motion to approve the block grant and a second. And a voice vote. All in favor, please indicate by saying aye. Aye. Any opposed? Okay. Thank you very much. And seeing no further business, we are adjourned. Oh, one last thing before we adjourn. We got notice that the reg that we just deferred, the optometry reg, it required a majority of the membership, not quorum. And so, with that being said, the reg will go into effect. Now we are adjourned.